Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 252 of our pharmacotherapy series, which majors in intra-abdominal infections. The first question reads, ROC, a 48-year-old man, presents with severe abdominal pain and nausea. He states he has been taking nonsteroidal anti-inflammatory drugs, NSAIDs, for joint pain over the last 2 weeks. An esophagogastroduodenoscopy reveals a perforated peptic ulcer. Vital signs include temperature of 38.7 degrees Celsius and tachycardia, with a pulse of 105 beats per minute. Bowel sounds are absent. Laboratory values are WBC count, 16.5 times 10 power 3 per microliter and a BUN of 34 mg per deciliter. So my question to you is, what signs and symptoms of secondary peritonitis does ROC display? Making the diagnosis of a localized intra-abdominal infection may be difficult, despite the presence of signs and symptoms typical of severe infection. Moderate to severe abdominal pain with anorexia, nausea, and vomiting are commonly experienced. Fevers with or without chills, tachycardia, sparse urination secondary to fluid loss into the peritoneum, faint or absent bowel sounds, and abdominal distension may accompany primary GI symptoms associated with peritonitis. Inflammation around the intestines and peritoneal cavity results in local paralysis and reflex rigidity of the abdominal wall muscles and the diaphragm, causing rapid and shallow respirations. These signs usually are accompanied by an elevated WBC count with a predominance of neutrophils, that is a left shift. The hematocrit and BUN may be elevated as a result of dehydration. Initially, patients are usually alkalotic owing to emesis and hyperventilation, but in the later stages of peritonitis, acidosis usually occurs. Untreated or partially treated peritonitis can result in generalized sepsis and hypovolemic shock, in addition to a gradual development of intraperitoneal abscesses. Therefore, patients with a sudden turn in disposition after treatment and recovery from peritonitis or abdominal surgery should be assessed for intraperitoneal abscess formation. ROC is likely to have a community-acquired intra-abdominal infection suggestive of a secondary peritonitis resulting from an acute perforated peptic ulcer after using an NSAID for 2 weeks. His current clinical status is highlighted by complaints of severe abdominal pain and nausea, fever with tachycardia, a significant elevation in WBC, and signs of dehydration with a BUN of 34 mg per deciliter. The next question reads, given these findings, what are the most likely pathogens for ROC's secondary peritonitis? Regarding the etiology, the normal flora consistent with the perforated segment of the GI tract determines the most likely pathogens, consisting of both aerobes and anaerobes the more distal the source. In general, the stomach and small bowel consist of few microbes, such as Candida species, lactobacilli, and oral streptococci, in the fasting state. However, the number and variety of gastric microbiota can increase with meals, achlorhydria, due to the use of histamine H2 blockers or proton pump inhibitors, obstruction, and presence of blood. The most common facultative bacterium is Escherichia coli, which is found in approximately 50% of cultures. A variety of other facultative gram-negative bacteria include Klebsiella species, Pseudomonas aeruginosa, Proteus species, and Enterobacter species. The presence of anaerobic bacteria in the culture is indicative of a polymicrobial infection with a predictable group of pathogens. Escherichia coli, Enterococci, and a predominant presence of obligate anaerobes, including Bacteroides fragilis, Prevotella melanogenica, Peptococcus species, Peptostreptococcus species, and Fusobacterium species, are found in the ileum and colon of the large bowel. Bacteroides fragilis is the most frequently isolated obligate anaerobe after perforation of the colon. Anaerobic cocci, Peptostreptococcus, and facultative gram-positive cocci, such as streptococci, are also isolated. Enterococcus species are isolated less frequently. Bacteroides fragilis and Escherichia coli are the most common pathogens found in blood culture samples after bacteremia related to an intra-abdominal infection. Highly antibiotic-resistant strains of Pseudomonas aeruginosa, Enterobacteriaceae producing ESBLs or Carbapenemuses, Acinetobacter species, and Enterococcus, as well as Candida species, are often isolated from hospitalized patients who experience secondary peritonitis. Gram stain and culture do not need to be routinely obtained in community-acquired intra-abdominal infections before the initiation of antimicrobial therapy. It may be useful in healthcare-associated infections for detection of gram-positive cocci, yeast or multidrug-resistant pathogens. The presence of pleomorphic gram-negative bacilli, a strong odor, or tissue gas is strongly suggestive of infection with anaerobes, particularly Bacteroides fragilis. ROC's secondary peritonitis is likely because of the presence of a facultative gram-negative bacteria, such as Escherichia coli, Proteus, Klebsiella, or Enterobacter, or possibly an obligate anaerobe, such as Bacteroides fragilis. ROC does not present with a history of hospitalization or recent receipt of broad-spectrum antimicrobials, therefore, an infection caused by more resistant healthcare-associated pathogens e.g., Pseudomonas aeruginosa, ESBLs, Carbapenemuses, is less likely. The next question reads, how should ROC be treated? On the basis of clinical studies, what empiric antimicrobial therapy is appropriate for ROC at this time? We will now discuss antimicrobial therapy. Let's begin with empiric therapy. Therapy for secondary peritonitis should include early administration of antimicrobial agents directed at facultative gram-negative bacteria and obligate anaerobes, fluid therapy, and support of vital organ function, as well as source control measures. Antibiotics should be administered within 1 hour of presentation of septic shock and within 8 hours after hospital admission in those with stable hemodynamic or organ status. Adequate source control involving surgical debridement and drainage, in conjunction with appropriate antimicrobial therapy, decreases morbidity and mortality. In general, when an intra-abdominal infection is present, antimicrobial agents should be started immediately after appropriate specimens, e.g., blood or peritoneal fluid, have been obtained and before any surgical procedures are performed. The parenteral route should be used to ensure adequate systemic and tissue concentrations, especially in patients in whom shock or poor perfusion of the muscles or GI tract precludes the use of oral administration. For mild to moderate community-acquired infections, empiric monotherapy with ertapenum, moxifloxacin, tigecycline, or cefoxitin is recommended. Moxifloxacin has good coverage against gram-positive and gram-negative aerobic organisms, excluding Pseudomonas aeruginosa, in addition to anaerobic organisms, and penetrates well into inflamed GI tissue, peritoneal exudates, and abscesses. Earlier concerns for resistance among Bacteroides species to moxifloxacin were re-evaluated in recent studies and found moxifloxacin to be a safe and effective monotherapy option for mild to moderate community-acquired complicated intra-abdominal infection. However, moxifloxacin should be used cautiously in infections with recent fluoroquinolone use. Tigecycline offers added in vitro activity against resistant pathogens such as MRSA, VRE, and penicillin-resistant Streptococcus pneumoniae. However, tigecycline lacks activity against Proteus species and Pseudomonas aeruginosa. Caution should be practiced when using tigecycline for severe infections, including complicated intra-abdominal infection, as the U.S. Food and Drug Administration announced a boxed warning of increased risk for mortality and non-cure rates. Therefore, the use of tigecycline should be considered when alternative antibiotic options are not available. Ertapenum is another monotherapy option for mild to moderate community-acquired complicated intra-abdominal infection. In comparative trials of ertapenum versus piperacillin tazobactam, the two agents were shown to be similar in efficacy and safety. Because monotherapy has been shown to be efficacious in numerous trials, combination therapy is now rarely used. Combination therapy with either a cephalosporin or a fluoroquinolone, ciprofloxacin or levofloxacin, plus metronidazole is also reasonable. For severe community-acquired intra-abdominal infections, meropenem, imipenem cilastatin, doripenem, and piperacillin tazobactam are empiric monotherapy options that may be used. An antipseudomonal third- or fourth-generation cephalosporin, fluoroquinolone, such as ciprofloxacin or levofloxacin, or aztreonam in combination with metronidazole represent alternative options for severe infections. Tertiary peritonitis is described as persistent peritonitis with systemic signs of sepsis even after appropriate management of the infection has been initiated. As a healthcare-associated infection, tertiary peritonitis often presents in critically ill patients and those immunocompromised where adequate source control may be improbable. With tertiary peritonitis, pathogens can vary from those that are less virulent such as enterococci, including VRE, coagulase-negative staphylococcal species, and Candida species to the more resistant healthcare-associated pathogens with little to no antibiotic options. Empiric use of meropenem, imipenem cilastatin, doripenem, or piperacillin tazobactam should be reserved for healthcare-associated infections in cases of sepsis and presumed or documented multidrug-resistant pathogens. Two new combination antibiotics, ceftolozane, tazobactam and ceftazidime, avibactam, both used with metronidazole, were recently approved for complicated intra-abdominal infection. Ceftolozane, tazobactam and ceftazidime, avibactam offer in vitro activity against challenging resistant gram-negative pathogens, including ESBLs and AMP-C producing Enterobacteriaceae and multi-drug-resistant Pseudomonas aeruginosa. Ceftazidime, avibactam also has in vitro activity against Klebsiella pneumoniae carbapenemesis. Empiric use of ampicillin sulbactam is no longer recommended for complicated intra-abdominal infections because of increasing rates of Escherichia coli resistance. Clindamycin and cefotatin are not recommended for community-acquired complicated intra-abdominal infection because of rising resistance rates from Bacteroides fragilis. The association of clindamycin with Clostridioides difficile-associated diarrhea has also resulted in the use of other options. With the risk of toxicity when using aminoglycosides, safer agents are now considered first-line treatment options. Fluoroquinolone-resistant Escherichia coli has become more common in the community. Caution should be taken when using fluoroquinolones empirically, particularly if hospital antibiograms indicate less than 90% susceptibility of Escherichia coli. Susceptibility patterns within the community and institutional antibiograms may assist with selection of optimal empiric antimicrobials when managing community-acquired complicated intraabdominal infection. ROC should receive antimicrobial therapy with activity against facultative gram-negative bacteria and anaerobes, including Bacteroides fragilis. Ertapenum 1 gram IV every 24 hours would be an appropriate treatment for ROC's mild to moderate complicated intraabdominal infection. The next question reads, how long should ROC receive antimicrobial therapy? Let's now discuss the duration of antimicrobial therapy. Recommendations for the duration of therapy for intra-abdominal infection vary from 4 to 7 days and depend primarily on the patient's clinical response to therapy and need for surgical drainage. In general, antimicrobial therapy should be continued until resolution of signs of infection takes place, including return of WBC count to normal and elimination of fever. The next question reads, BOB is a 58-year-old, non-obese woman with gangrene of the bowel from strangulation. One day after undergoing surgical resection of the duodenum, she has a fever of 38.9 degrees Celsius, shaking chills, and abdominal pain. Laboratory values include a WBC count of 18.4 times 10 power 3 per microliter and creatinine of 1.1 mg per deciliter. BOB's peritoneal fluid cultures grew Escherichia coli, Bacteroides fragilis, Candida albicans, and Enterococcus. Blood cultures are negative. Should she receive additional antimicrobial therapy active against Enterococcus? Although Enterococcus is commonly cultured in patients with secondary peritonitis, its pathogenicity has been questioned. Enterococcus can cause serious infections, e.g., endocarditis, or urinary tract infections, but it is less virulent in the setting of polymicrobial infections such as intra-abdominal infections. An important issue is whether empiric treatment should include antibiotics with activity against Enterococcus. Some investigators believe that Enterococcus species are commensal organisms that need not be treated in most clinical settings. They point to clinical studies in which antibiotic regimens lacking in vitro activity against Enterococcus have been successful. The pathogenicity of Enterococcus lies in its ability to enhance the formation of abscesses. The presence of Enterococci suggests active disease. However, use of anti-enterococcal antibiotics has not shown to improve outcomes. In general, coverage is warranted if Enterococcus is present in blood cultures or is the sole organism on culture. Anti-enterococcal therapy is recommended in patients with nosocomial or healthcare-associated infections, particularly those who received antibiotics selecting for Enterococcus species, e.g., cephalosporins, are immunocompromised, have postoperative infection, or have valvular heart disease or prosthetic intravascular materials. If susceptible, Enterococcus species should be treated with ampicillin or piperacillin, tazobactam. Vancomycin should be reserved for ampicillin-resistant Enterococcus, whereas VRE can be treated with linezolid or daptomycin. Because BOB's blood cultures are negative and a cytic culture has demonstrated mixed pathogens, Enterococcus coverage, specifically VRE, may not be necessary. BOB should be treated with an antimicrobial regimen that has activity against gram-negative pathogens, anaerobes and susceptible Enterococci for a postoperative infection. The next question reads, should BOB's antimicrobial therapy include an agent with antifungal activity? Let's discuss antifungal therapy, treatment of Candida. The need to treat Candida species as a solitary isolate or as part of a polymicrobial infection is controversial. Certainly, Candida has the potential to cause peritonitis, IP abscesses, and subsequent candidemia. Mortality resulting from Candida peritonitis ranges from 25% to 60%. Risk factors for Candida peritonitis have included recurrent abdominal surgery, GI tract perforation, particularly in those untreated within the first 24 hours, surgical drains, intravenous and urinary catheters, severe sepsis, and colonization by Candida species. Significance for intra-abdominal candidiasis worthy of treatment rises when Candida species are isolated surgically or directly from an intra-abdominal collection, e.g., within 24 hours of drain placement, in patients with severe community-acquired or healthcare-associated infections. This may include patients who recently received immunosuppressive therapy for neoplasm, has a perforated gastric ulcer while on acid suppression, has malignancy, transplantation or inflammatory disease, or a postoperative or recurrent intra-abdominal infection. Echinocandins and azoles are initial options for fungal peritonitis. Concerns about the toxicity of conventional amphotericin B have limited the use of this agent. To date, no clinical trials have assessed the efficacy and safety of lipid-based amphotericin B azoles or echinocandins in the treatment of intra-abdominal fungal infections. Fluconazole is considered an appropriate drug of choice for Candida albicans. For Candida glabrata or other fluconazole-resistant species, an echinocandin, caspofungin, micafungin, or anagula fungin, or an amphotericin product is an appropriate option. If critically ill, initial therapy with an echinocandin is recommended. Therapy with an antifungal agent such as fluconazole 400 mg daily is acceptable for BOB and the Candida albicans isolated. The next question reads, the surgical resident-initiated piperacillin tazobactam for the treatment of BOB's intra-abdominal infection. Should culture and sensitivity results be used to monitor for anaerobic activity? We will briefly look at anaerobic bacteria. With the introduction of broad-spectrum antimicrobial agents with in vitro activity against Bacteroides fragilis and a significant problem of increasing resistance, the choice of a specific anti-anaerobic agent has become more complex. Multiple mechanisms of resistance are encountered, and resistance rates differ among various geographic areas of the United States. Although Bacteroides resistance to metronidazole is rare, resistance to clindamycin has increased substantially. Although the carbapenems and the beta-lactamase inhibitor combinations are exquisitely active against Bacteroides, occasional resistance has been reported. The Clinical and Laboratory Standards Institute has suggested that susceptibility testing be performed only to determine patterns of anaerobic susceptibility to new antimicrobial agents and to monitor susceptibility patterns periodically on a geographic and local basis. Because most anaerobes are cultured in the setting of mixed flora, isolation of individual components of a complex mixture can be time-consuming. In addition, most anaerobes are very slow-growing, and it may take days to weeks for a definitive culture and sensitivity report. If specimens are not collected and transported in optimal media or in a timely manner, inaccurate or misleading results may be reported. The methods for susceptibility testing of anaerobic bacteria are not well standardized, and many hospital laboratories do not have resources to perform extensive culture and sensitivity testing. Routine cultures rarely impact the choice of antibiotic regimen, and thus the empiric choice of therapy usually determines the outcome. Routine susceptibility testing for patient-specific cases is not recommended because of the prolonged time needed to achieve results, but it may be useful when resistant organisms are suspected or high-risk patients have been identified. The next question reads, RSK is a 28-year-old woman with a history of diverticulitis, who presents with abdominal pain and distension, fever, and chills. An intra-abdominal abscess is visualized by CT scan. How did this abscess develop? What considerations should be taken into account in the selection of appropriate antimicrobial agents? Abscesses are collections of necrotic tissue, bacteria, and WBCs that form during a period of days to years. They generally result from chronic inflammation and the body's attempt to localize organisms and toxic substances by formation of an avascular fibrous wall. This process isolates bacteria and the liquid core from opsonins and antimicrobial agents. Regarding the microbiology, pathogens encountered in intra-abdominal abscesses often include facultative aerobic gram-negatives, e.g., Escherichia coli, and obligate anaerobes, e.g., Bacteroides fragilis. Mixed infections involving Escherichia coli or Enterococci with Bacteroides fragilis have been associated with a synergistic mechanism responsible for late intraperitoneal abscess development. Regarding antimicrobial therapy, abscesses pose a therapeutic challenge because they typically contain large bacterial inocula that are likely to include subpopulations of resistant bacteria. Furthermore, the rate of penetration of antibiotics into abscesses is hindered by the low surface-to-volume ratio, low pH, and decreased permeability. Although percutaneous drainage or surgical debridement of RSK's abscess is crucial, adjunctive therapy with antimicrobial agents is warranted. The optimal antimicrobial agent should penetrate into the abscess in adequate concentrations and have an adequate spectrum of activity. RSK should be placed on an antimicrobial regimen, such as piperacillin tazobactam 3.375 grams IV every 6 hours, that covers gram-negative bacteria and anaerobes. The next question reads, STI, a 19-year-old man, is admitted to the emergency department within 1 hour after sustaining a gunshot wound to the stomach and colon. He is to undergo emergency laparotomy. What antimicrobial therapy is appropriate at this time? As with other types of intra-abdominal infections, antibiotics active against both aerobic and anaerobic pathogens should be used. Anti-infective therapy has been studied in patients who have sustained penetrating trauma to the abdomen, usually from knife or gunshot wounds. In several comparative trials, single-drug therapy with cefoxitin was as effective as the combination of clindamycin or metronidazole plus an aminoglycoside. In evaluating these studies, however, it is important to note that most patients did not sustain injuries to the colon, where the risk of infection is highest. Although the age of this patient suggests he would tolerate aminoglycoside therapy, monotherapy with cefoxitin or one of the beta-lactamase inhibitor combinations would be appropriate. Consensus guidelines regarding the duration of therapy were published by the Eastern Association for the Surgery of Trauma, abbreviated as EAST, Practice Management Group. These investigators reviewed all literature from 1976 to 1997 regarding the duration of antimicrobial use after penetrating abdominal trauma. They concluded that antimicrobial use should not exceed 24 hours in this patient population. The next question reads, how long should antibiotic therapy be administered to STI? The shortest duration of antimicrobial therapy that has been shown to be effective has been 12 hours, with the possibility that a short course, that is shorter than 48 hours, is as efficacious as 5 to 7 day course if antimicrobial therapy is promptly instituted. Several other trials have confirmed no additional benefit exists in providing a longer treatment duration. Because antimicrobial therapy carries a risk of adverse reactions, development of resistance, and unnecessary costs, short-term therapy seems warranted as long as it is instituted soon after the injury. If the initial dose of antibiotic is administered more than 3 to 4 hours after injury, therapy should be continued for 3 to 7 days because the incidence of infection in this circumstance is high. Antimicrobial therapy was instituted soon after STI sustained the colonic injury. Therefore, a short course of antimicrobial therapy is appropriate. Therapy should be continued for 24 hours. The next question reads, GSR is a 12-year-old girl with a 2-day history of periumbilical pain migrating to the right lower quadrant, abdominal distension, fever of 39 degrees Celsius, diarrhea, and decreased bowel sounds. Her WBC count is 15.8 times 10 power 3 per microliter. A presumptive diagnosis of acute appendicitis is made. So my question to you is, what antimicrobial therapy is indicated, and for how long should it be continued? Clinical manifestations commonly encountered with acute appendicitis include right lower quadrant abdominal pain, rebound tenderness, and low-grade fever complicated by nausea, vomiting, and anorexia. A variety of antimicrobial agents are effective in the treatment of acute appendicitis. Antimicrobial therapy selection for uncomplicated appendicitis can follow those recommended for community-acquired intra-abdominal infection where therapy for less than 24 hours is sufficient. Patients with gangrenous or perforated appendices are associated with the highest risk of infection. In several well-designed, randomized, placebo-controlled trials, therapy with imipenem C-listatin, beta-lactams, and beta-lactamase inhibitor combinations has been found to be as effective as the combination of clindamycin or metronidazole plus an aminoglycoside. Patients with gangrenous or perforated appendices who were afebrile for 48 hours have been treated for durations ranging from a single dose to 3 to 5 days. GSR should receive a preoperative dose of beta-lactam antimicrobials with activity against facultative gram-negative and anaerobic bacteria, such as cefoxitin alone or cefazolin plus metronidazole. Cost, potential side effects, and ease of administration guide selection of a specific agent. If a gangrenous or perforated appendix is found during surgery, antimicrobial therapy should be continued for a minimum of 3 to 5 days or until GSR has been afebrile for 48 hours. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 253.